Let's talk about radial keratotomy, or RK, and how to actually fix it. Radial keratotomy was the procedure for treating mainly nearsightedness, although there were some hyperopic procedures, with incisions in the cornea that actually flattened the center cornea to create the refractive effect. They were weakening the cornea by making wagon wheel-like spokes in the cornea, causing a flattening of the central cornea to create a refractive effect by literally weakening the cornea itself. For that to actually have a uniform effect, every single one of these hand-placed incisions would have to be the same length, the same depth, and be placed perfectly in relation to the other. The chance of that happening with hand-placed incisions is very, very low. We've seen a variety of RKs here, some more regular than others, but all of them have some level of irregularity. So the first part of the problem that RKs have is they're all irregular. And when they're irregular, that means that when you actually have the light pass through, it gets scattered, and that causes the halos, the glare, the multiple images, the loss of sharpness, the loss of actual ability to see resolution. The second thing that happens is that we have, usually in these patients, they don't end up the proper refractive correction. There's a hyperopic shift, it's called. And most of these patients end up farsighted with some astigmatism. They end up with significant refractive error. And what happens is the ability to accommodate or compensate for this worsens with the same worsening that worsens or affects the reading. And so the lens actually gets stiffer as you get older. And I think from what we see is that the brain itself has a tougher time as you get older compensating for visual aberrations, the irregularity itself. So problem number one, irregularity. Problem number two, big refractive errors, usually hyperopic. And then the third problem is because the cornea is weakened, it can actually have fluctuations. The pressure inside the eye changes normally in people throughout the day. It's called a diurnal variation. And that variation in certain people, more than others, flex the cornea in and out and change that prescription. Those are the three problems that RK has. And depending on the severity, let's say someone's a little less irregular, but they have a big refractive error and only a little fluctuation. Some people have big fluctuations, some people have big irregularity, but they all have some proportion of all of these problems. You can fix the first two, but you have to understand how those are fixed. The fluctuations you can't fix, but you can deal with that if you fix everything else, they become more of a minor nuisance. And then you can perhaps set the final prescription when after doing the other fixes that falls in between the fluctuations so it really doesn't bother you too much. In other words, it fluctuates around zero, and so it doesn't bother you too much. So the big stuff is the first two. And there are various ways to deal with it. A lot of people do this saying, okay, let's do cataract surgery or lens exchange or ICLs. We'll do some sort of lens surgery. The thing is, the lens surgery only fixes the refractive error. It fixes the prescription. It cannot fix the irregularity of the cornea. So you can have a decrease in refractive correction and still have all the other problems associated with it, depending on how irregular the cornea is. And you can have irregularity limit the actual vision of the actual system itself. We have plenty of RK patients that can only get 2, 3, 4 lines of vision, because when you fix the irregularity, the vision is actually better, more cohesive, homogeneous, not just refractively better. So when you change lenses, you're fixing only the refractive error. It's like putting a pair of glasses on or wearing a contact lens. To fix the irregularity, you have to then use either a scleral lens, which creates a new hard surface over the front with a tear sandwich making up and compensating for the irregularity that allows you to see better. Some doctors advocate cornea transplants for very irregular RKs. This is like exchanging one irregularity for another irregularity, because every cornea transplant has some of the same problems. You're taking a cornea from a donor, it's not going to be matched perfectly to the shape of your cornea, and then what happens is you're going to have that cornea hand stitched in, and every stitch would have to be the exact same length and the exact same bite and the exact same pull for it not to be irregular, and that's not going to happen. And you then have the problems with rejection and all those things. So I don't think cornea transplant is probably the best solution for RK people at all. The way to fix the cornea is to use topographic guided ablation. We take a map of the cornea and we segmentally whittle down the cornea to make it a uniform shape again. This is not PRK. You know, doctors say you shouldn't do PRK, it'll just flatten you more. This is a segmental correction to make the shape one shape instead of a whole bunch of kind of whoop-de-doos. That segmental correction is a reconstruction of the cornea. And the cornea is going to end up flat because the RK made it flat. So you also then will have to change the shape of the cornea by doing a hyperopic correction to raise the shape. And you do that by taking out tissue from the outside, so it essentially creates a central area and the visual axis that's the proper curvature. That is what can be done with a topography guided laser. Wavefront guided lasers like a Vizx can't do this. They don't map the cornea alone. They don't map it with the resolution. A wavefront guided laser like the Vizx is an eye design laser. It does a map of the whole eye. It only has 1,000 points. A topography guided machine has 22,000 points of information, and it does the cornea directly. And this is what we do. We map and reshape the cornea to make it a more normal shape, to get rid of those visual aberrations, to have a chance for an increased amount of vision, better resolution. The retina gets a more homogeneous amount of light, therefore it creates a sharper, clearer image. And then we also treat to fix the residual refractive error, okay? And that we do all by laser. It can be done in conjunction with cataract surgery in between. This is important for people to realize that the different choices have different consequences on what they're trying to fix. This is the problem. RK patients, a lot of them don't get enough information to say, hey, what are we fixing here? Well, the things that have to be fixed are, one, the irregularity, and two, we got to fix the refractive error. And you need both. Like, we can't even do just one type of laser correction to fix both things. We have to do two types of laser correction to fix both things. You can't just do one thing unless somehow that cornea is not very irregular. You do a cataract surgery, vision's great. Or you do a refractive surgery to fix the vision, like a regular PRK, vision's great. And that's what we used to do before we had topography guided ablation. That definitely helped RK patients. Definitely did. If you just do a regular PRK, right? Or if you just do a cataract surgery, a lens exchange, or ICL, when you get rid of 4 diopters of hyperopia, boy, it's pretty helpful. But if you have corneal irregularity or significant corneal irregularity, then you still have significant problems. It doesn't fix the problem. If you happen to be lucky enough to get somebody who had a really great hand and made those incisions really as close to even as possible, and you don't have a lot of irregularity, you're gonna do great with a PRK. You're gonna do great with lens surgery. But as soon as the irregularity starts piling up, it doesn't do as well. And so when you pick your solutions, you have to understand the science. What are we fixing? And what exactly is going on? So again, fix the irregularity is only topography guided ablation. Fix the refractive error, you can use PRK laser, you can use lens exchange, cataract surgery, or an ICL. And all of that is going to then be adjusted if there's any fluctuations, either by a light adjustable lens on cataract surgery or by laser enhancement if it's fluctuating, to make sure that we get it around one central point so the fluctuations don't bother you too much.